Okay, welcome back. In this video, we'll go over chapter number 13, the respiratory system. It's a gas. A brief introduction to the chapter. The respiratory system's primary function is to transport oxygen from the atmosphere into your bloodstream so it can be used by your cells. So it can be used by your cells, your tissues, your organs for the process of cellular respiration, which is necessary to sustain life. The respiratory system moves about 12,000 quarts of air per day in and out of your lungs. That's also responsible for removing waste gas, such as carbon dioxide, so it doesn't build up to toxic levels. Some learning objectives for this chapter. List and state the basic functions of the components of the respiratory system. Differentiate between respiration and ventilation. Explain how the respiratory system warms and humidifies inhaled air. State the purpose and function of the mucociliary escalator. Be able to differentiate between upper and lower airways and their functions. Be able to discuss the process of gas exchange at the alveolar level. Describe the various skeletal structures related to the respiratory system. Explain the actual process of breathing. And lastly, discuss several common respiratory system diseases. First, start with a system overview. Cellular respiration depends on a continuous supply of oxygen, which is found in abundance in the air that we breathe. Using oxygen produces carbon dioxide as a waste byproduct. This can become toxic if allowed to build up in your bloodstream, so it has to be removed. The respiratory system is very closely related to the heart and circulatory system, and sometimes they are grouped together as the cardiopulmonary system. The components of the respiratory system include the two lungs that serve as vital organs, the upper and lower airways that conduct gas in and out of the system, the terminal air sacs called alveoli that are surrounded by a network of capillaries that provide for the actual gas exchange, the thoracic cage that houses and protects and facilitates the function of the system, and the muscles of breathing that include the main muscles, the diaphragm, and the accessory muscle. Here are some various components of the respiratory system. Of course, the nose and mouth up here. See the nasal cavity, the pharynx, different components of the pharynx, the trachea, the primary bronchi left and right, and two lungs, and of course the diaphragm. Zooming in close here, you have the tiny air sacs where all the gas exchange happens, the alveoli. Now we'll talk about ventilation versus respiration. Now, air contains many gases, predominantly nitrogen, which is a support gas that helps keep the lungs open with a constant volume and pressure. Now, the next highest concentration in the air we breathe is oxygen, which is essential to life. And also, carbon dioxide is found in very small concentrations. Now, ventilation, this is the bulk movement of air in and out of the lungs, where gas exchange will take place. So nothing is being exchanged, it's just the generic moving of air into the lungs and then out of the lungs. Now, respiration is the process of gas exchange, where oxygen gets added to the blood and carbon dioxide gets removed from the blood. There are various forms of respiration. For external respiration, this is the gas exchange in the lungs that occurs between the blood and the air of the atmosphere. Now, compare that to internal respiration, where you have oxygenated blood transported internally via the cardiovascular system to cells and tissues. So oxygen moves into cells as the carbon dioxide is removed. So for external respiration, you have gas exchange between the air and the blood, and for internal respiration, you have gas exchange between the blood and the cells. So it's a more internal of a process. That's why it's internal respiration. Here's a breakdown of the gases in the atmosphere based on percentage. Nitrogen, by far the highest in percentage, about 78%. Then oxygen, about 21%. And then carbon dioxide, very, very small percentage, along with argon, very small percentage. And there are some other trace gases that are present, such as krypton and neon. Here's a comparison of internal versus external respiration. For external, is this image here. You have gas exchange between the air that's in the atmosphere, which ends up in your lungs, and the blood. And then internal respiration would be between the blood and the actual cells themselves. Now we'll talk about the airways and the lungs. We have a reserve of oxygen that can last anywhere from 4 to 6 minutes. Beyond that point, we will die if we don't get any more oxygen. So the respiratory system is a series of branching tubes called bronchi and then bronchioles. Okay, and these will transport atmospheric gas deep within the lungs to very small air sacs called alveoli, which represent the terminal end of the respiratory system. Now, alveoli is plural. Alveolus is a singular air sac, but you'll almost always see these referenced as alveoli because we'll talk about them in the plural form. Okay, each alveolus is surrounded by capillaries, and this combination of the capillaries and the alveoli is called the alveolar capillary membrane. And this represents the connection between the respiratory system and the cardiovascular systems. Alright, now we'll talk about the two various airways, both upper and lower, and how they are different. The upper respiratory tract, or the upper airway, will consist of the nose, the mouth, the pharynx, and the larynx. And these functions of this airway will include heating or cooling of inspired air gases to body temperature, filtering the air that's breathed in, and also humidifying the air. Some other functions include the actual sense of smell, or the sense of olfaction, producing sounds and phonations, and ventilation, or conducting gas to the lower airways. Now, some people breathe through their mouth. We are meant to breathe through our noses. That's because the air becomes humidified faster and filtered faster when you breathe through your nose. Right, just behind the nose is the nasal cavity, which is divided into three main regions. You have the vestibular, the olfactory, and the respiratory regions. So you have the opening to the nose here, the nair. You have vestibular region here, respiratory region here, and olfactory region up here. So all of that is the nasal cavity. Alright, the vestibular region is located inside the nostrils. It contains the coarse nasal hairs that act as a line of defense for the respiratory system. And these hairs are covered with a sebum, which is a greasy substance secreted by sebaceous glands of the nose. And this is there to help trap particles. It also keeps the hairs in your nose soft and pliable. So the whole point here is to filter things from getting any further inside your respiratory tract. You don't want larger particles entering the trachea or entering the lungs, so they get filtered by the sticky sebum and then getting caught within the hairs itself. The olfactory region is located on the roof of the nasal cavity. This will allow air to be held there so it can be sampled. And then the respiratory region, the air gets warmed to body temperature and moistened in this region, which is just inside the nasal cavity, which is lined with mucous membranes, which is richly supplied with blood. Now, there are three scroll-like bones called turbinates that split incoming air into three different channels, providing for more surface area. Alright, these turbinates serve to make the incoming air current a lot more turbulent, a lot more violent, which will bring in more air into contact with the mucous membranes. So you have more air that gets warmed and more air that gets exposed to moisture. And this can add up to anywhere between 650 to 1,000 milliliters of water each day to moisten the air and increase the humidity to about 80% relative humidity. So the more it churns around these turbinates, the more moisture it's collecting, the warmer it is becoming. Alright, now I'll talk about a pathology connection regarding the nose. Talk about allergic rhinitis. Now, this occurs when allergens, such as pollen, trigger the nasal mucosa to secrete excessive mucus. Some common treatments: antihistamine medications, allergy injections that desensitize the person to an allergen. Basically, a runny nose. You have the inflammation of the nose itself, which causes the nasal mucosa to secrete more mucus than is necessary, so the mucus will run out of your nose. Nasal polyps. These are non-cancerous growths that are found within the nasal cavity. These may be related to chronic inflammation, and these can be surgically removed if they become large enough where they actually block the nasal passages. All right, now we'll talk about the mucociliary escalator. Now, the cells in the epithelial lining of the airways of the respiratory system are called pseudostratified ciliated columnar cells. These are a single layer of tall column-like cells that have nuclei at different heights. That's why they're called pseudostratified. So they may look at first glance that they're stratified or have multiple layers, but they're not. They're cells of different sizes. Now, each of these columnar cells has 200 to 250 cilia on its surface. Now, goblet cells and these submucosal glands are interspersed and produce. Now, the mucus resides as two separate layers. The cilia resides in the sole layer, which contains a thin, watery fluid that allows them to beat freely. And the top layer is a gel layer, which is a lot more viscous and a lot more sticky, and is what will trap small particles. Now, the cilia basically act as tiny little oars resting in the watery sole layer. And these oars will basically beat back and forth, like you are rowing on a boat. And these cilia can beat anywhere from 1,000 to 1,500 times per minute, and they propel the gel layer and all the junk that's trapped inside it onward and upward about 1 inch every minute to be expelled. Now, in the nose, debris-laden secretions push toward the nasal cavity to be expelled through the nose. So basically, when you blow your nose, this is what is being expelled out, the stuff that's been propelled forward to your nose. So the cilia that are found on these pseudostratified columnar cells will propel this gel layer toward the oral cavity to be expectorated with cough or swallowed into the stomach. So either way is to get rid of the debris it is trapped. Either so you can cough it out, spit it out, or if you swallow it, it'll go down to the stomach to be destroyed. Okay? And here's how the mucociliary escalator looks. You have the submucosal gland here, and the goblet cells here. The goblet cells are what make mucus. Pseudostratified layer of columnar cells here. The cilia on top. Then you have the sole layer here, and then the gel layer right above it. The cilia are able to beat back and forth like little oars in this watery layer, and then particles will get stuck in the thicker, more viscous layer, that gel layer. And both of those together make up what's called the mucus blanket. Alright, the skull will contain air-filled cavities called sinuses that connect to the nasal cavity via small passageways. And these are located around the nose and sometimes referred to as the paranasal sinuses. Now, these cavities will help prolong and intensify the sound produced with our voice. It also helps to lighten the weight of your skull. Now, this is why whenever you are sick with a cold or a flu and you are congested, this is the reason why your voice sounds different. Because you are filled with mucus and your voice can't resonate through your sinuses like they normally would. You're basically muffling the sound waves. You're altering how your voice sounds coming out of your head. Now, the sinuses do not exist when we're first born. These will develop as we grow. Now, changes in our facial features are influenced by our sinuses as we mature. And the sinuses are also there to help warm and moisturize the air that we breathe. Common locations of our sinuses: you have the frontal, here, right in front. The ethmoid sinuses, the maxillary, here. Or sphenoid sinuses, here. Now, the pharynx, or a throat, is a hollow muscular structure beginning just behind the nasal cavity, and it's lined with epithelial tissue. It's divided into three sections: nasopharynx, oropharynx, and laryngopharynx. And the prefix of each one of these tells you where they're located. The naso is always a reference to the nose. Oro is always a reference to the oral cavity or the mouth. And laryngo is always a reference to the larynx. Okay, here's the nose here. So nasopharynx is behind there, right behind the nasal cavity. Oropharynx is behind the mouth. That's the tongue kind of pulled up at an angle. And laryngopharynx is by the larynx. Now, the nasopharynx is the uppermost section, beginning behind the nasal cavity. And this section will contain a lymphatic tissue called adenoids, and also the passageways into the middle ear called the eustachian tubes. And the air from the nasal cavity will pass through the nasopharynx. The oropharynx is located just behind the oral cavity. This conducts not only atmospheric gas, but also food and liquid. Air breathed through both the nose and the mouth will pass through here, as does everything else that is swallowed. Okay. In this oral cavity, you also have the tonsils, and the tonsils are part of the lymph system. The palatine tonsils are located in the oropharynx, as are the lingual tonsils, which are just at the back of the tongue. During swallowing, the uvula and the soft palate will move in posterior and superior positions to protect nasopharynx and the nasal cavity from entry of food or liquid. That's going to be overcome by a forceful laugh. This is how fluids like milk, for example, can actually go through your nose. If you are drinking something and you start to laugh really, really hard, suddenly, that's how it can be forced back out through your nose. The lowermost portion, the laryngopharynx, the air that's breathed in or swallowed passes through the laryngopharynx. Now, swallowed materials will pass through the esophagus to get onto the stomach, and then air will travel through the larynx and the trachea on its way to the lungs. See, the larynx is another term for your voice box. This is a semi-rigid structure that's composed of various forms of cartilage and muscles and connective tissue, and these provide movement for the vocal cords to control speech. Now, one type of cartilage, the thyroid cartilage, is what will form the Adam's apple, which is much more prominent in males compared to females. And it's the largest of the cartilages that are found in the larynx. The cricoid cartilage lies just beneath that, providing a structure and support for the airways so they don't collapse. And the glottis is the opening that leads into the larynx and eventually the lungs. When someone gets intubated, you are entering the tube through the glottis down into the trachea. See, the glottis is covered with a leaf-shaped flap-like piece of fiber cartilage called the epiglottis. And this closes over the opening to the larynx whenever we swallow, and will open up as we breathe, as part of the swallowing reflex, also called the glottic mechanism. So whenever you swallow, your tongue will push down the epiglottis so food doesn't get into the trachea and then go into your lungs. So whenever you eat too quickly or eat too much, or perhaps both of those, if the epiglottis doesn't close in time, you'll get food going down the wrong way. And that literally means it's going down the wrong path and going into the trachea, into the lungs, which is why you start to choke, which is why you start to cough violently to get rid of that food and get it out of your trachea. See, the vocal cords act as a dividing line between the upper and lower airways. The lower airway starts just below the cords, and the upper airway will end at the vocal cord. All right, now we'll talk about another pathology connection with the upper airways. First off, the common cold. This is caused by over 200 different strains of viruses. This causes acute inflammation of the upper respiratory mucous membranes, and you treat this by managing the symptoms. Now, it can be prevented with some basic hygiene, such as good hand washing. Now, this should not be confused with allergies or the flu. These are all three different diagnoses. And what causes a cold is different than what causes the flu, which is different than what causes allergies. So they're not all the same. They may have similar symptoms, but they're all caused by different agents. Now, here's a comparison of allergies and cold and flu, going from, say, onset, of course, depending on the allergen. For cold, that is a slow onset. For flu, it's very fast. Duration, for the cold, usually about 1 week. For a flu, it could be much longer. Time of year, of course, that will depend on the allergen. See, the presence of fever. For allergies, you won't have any fever. If you do, it's going to be most likely the flu. If you do have a fever with a cold, it's going to be fairly mild, less than 100 degrees. So other symptoms such as the degree of fatigue, sneezing, sore throat, stuffy nose, cough, and so on. Good comparison between all three of these. They may present the same way. They're all caused by three different causative agents, which is why these symptoms are all different. All right, sinusitis. This is an infection and inflammation of the sinuses by viruses or bacteria. This can cause increased pressure, pain, and also headaches. See, tonsillitis. This is an inflammation, swelling, and the pain of the tonsils. And this may require tonsillectomy if it's severe enough. Pharyngitis is another term for sore throat. See, and strep throat is caused by the bacteria Streptococcus. Laryngitis is an inflammation of the voice box, of the larynx, characterized by hoarseness and a loss of speech. It's caused by an infection or the excessive use of your voice. There are some various structures of the upper airways and what could affect each one. You have sinusitis up here for the sinuses, acute rhinitis, pharyngitis, tonsillitis, laryngitis. See, acute epiglottitis. This is a potential airway emergency infection that causes the swelling of the epiglottis and also causing airway obstruction. This is typically caused by the virus H. influenza type B, is most common in children ages between 2 and 6, and the incidence of this condition is decreasing since the introduction of the Hib vaccine. Common symptoms of this condition: acute swelling of the epiglottis, fever, and sore throat. Often has a rapid onset, which requires a very rapid treatment to counter it. And treatments would include maintaining the airway and antibiotics. The next one, LTB, laryngotracheobronchitis, is an infection of the laryngeal area characterized by a noisy breathing, especially on inspirations or inhaling. Symptoms include a barking cough, inspiratory stridor. This is a high-pitched sound heard when the patient inhales. You're able to hear it even without using a stethoscope. And this disease is previously called a croup. Sleep apnea is where your breathing will stop during sleep. This is caused by the soft tissue at the back of the throat relaxing and then eventually blocking your airway. This can lead to fatigue during the day because you never got a good night's sleep, so you are fatigued whenever you do wake up. Now, long-term undiagnosed sleep apnea can cause some other health problems, such as high blood pressure, weight gain, and headaches. Now, this can be diagnosed during a sleep study, where a patient is monitored as they are sleeping. Treatment could include special pillows and positioning the patient in order to help them keep their airway open. Weight loss can also lessen the severity of the condition. And more severe obstructive sleep apneas may be treated with oral appliances, breathing devices, or even surgery. Right, now we'll talk about the lower respiratory tract. Now, this resembles an upside-down tree, sometimes called the tracheobronchial tree. From the vocal cords, the air will enter the trachea, or the windpipe, which is a long tube that's lined with ciliated mucous membranes. The trachea will extend from the cricoid cartilage of the larynx to the sixth thoracic vertebrae. Now, the trachea is held open by rings of cartilage in a C shape. They're found in the anterior portion of the trachea. That's why you're able to feel your trachea in the front of your throat. Now, the esophagus will lie in an area where the C opens and the ring doesn't completely go around. So this will leave room for the esophagus to expand whenever you swallow food. Here's an illustration of the tracheobronchial tree. The thyroid cartilage up here, which forms the Adam's apple, and the larynx, which would be the voice box. Trachea here. You can see the individual C-shaped rings of pilot and cartilage here. As it continues down, it will split into the right-left primary bronchi. So the trachea is the largest pipe of this respiratory system, and it can be thought of as the trunk of a tree. Now, the trachea will begin to branch at the center of the chest into right and left primary bronchi. Now, bronchi is the plural term, and the single form of that word would be bronchus. There's a left bronchus and a right bronchus. And this branching is called bifurcating. Now, the site where this bifurcation occurs is called the carina. That's the actual site where the trachea splits into two different forks. Now, the next bronchi must branch into 5 lobular bronchi. These will correspond to 5 lobes of the lung. The right lung has 3 lobes, and the left lung has 2 lobes. Now, each lung lobe is further divided into specific segments, and next branching of the bronchi is called segmental bronchi. So, going from trachea down to the segmental bronchi, the tissue layers of the bronchi are all the same, just smaller. They get progressively smaller and smaller and smaller as you get further down into the bronchial tree. The epithelial layer will contain the mucociliary escalator. The middle layer is the lamina propria, which will contain the smooth muscle and the lymph and the nerve tracts. And the third layer is the protective and supportive cartilaginous layer. So from the trachea all the way down to the segmental bronchi, it's the same setup all the way down, just smaller and smaller and smaller. So here you have the trachea up here, then where it would split into the left lung to the right lung. So left bronchus, right bronchus. And you're zooming in closely on this segment here. And the branching becomes more numerous with tiny subsegmental bronchi that branch deep into each lung segment. And these cartilaginous rings become more irregular and eventually will fade away. As we move toward the actual gas exchange regions, the airways will simplify to make it easier for the gases to pass in and out of the alveoli. And the bronchioles will average about 1 millimeter in diameter. There is no layer of cartilage here in bronchioles. what you have is the epithelial lining will become more ciliated, cuboidal, as opposed to having long column-shaped cells. So they become more cube-shaped as opposed to column-shaped. Also at this point, the cilia, the goblet cells, and the submucosal glands are almost all gone. But you still don't have any gas exchange happening just yet. The terminal bronchioles have an average diameter of about 0.5 millimeter. You still have no goblet cells, no cartilage, no cilia, or no submucosal cells at this point either. Now the terminal bronchioles mark the border between the conducting zone and the respiratory zone. So the next airways beyond the terminal bronchioles are called the respiratory bronchioles, because this is where gas exchange actually occurs, in the respiratory zone. The epithelial lining is now simple cuboidal epithelium, interspersed with the alveoli type cells called simple squamous pneumocytes. Now the alveolar ducts will originate from the respiratory bronchioles, and where walls of the alveolar ducts are made up of simple squamous cells arranged in a tubular configuration. Now it's these that will give rise to the alveoli, where you actually have the gases exchanged. Right, so zooming in on one of these clusters here, they actually look like clusters of grapes, but each pocket is a terminal air sac and alveolus. And on this table here, it's listing the number of divisions off of the trachea, and it's breaking it down into the conducting zone and to the respiratory zone. So for example, the conducting zone covers from the trachea all the way down to the 19th branch off of that trachea. So from 0 to 19 branches, that's considered the conducting zone. No gases get exchanged there. Gases get exchanged in the respiratory zone. So from the 20th division off of the trachea up to the 28th, which leads to the alveolar sacs. Now the alveoli are the terminal air sacs, and they're going to be surrounded by a large number of pulmonary capillaries. Now together, capillaries and the alveoli make up the functional unit of the lung, known as the alveolar capillary membrane. Now adults will have anywhere between 300 to 600 million alveoli, which will cover a total of about 80 square meters of surface area. And the more surface area you have, the more functional tissue you have to exchange oxygen and carbon dioxide. Now blood from the right side of the heart is blood that has no oxygen in it. So the blood from the right side of the heart entering the pulmonary capillaries is high in carbon dioxide but low in oxygen. And conversely, carbon dioxide is high in the blood in pulmonary capillaries but very low in the lung. So the gas exchange will take place, so carbon dioxide will leave your blood and go into your lungs so you can exhale it. The oxygen will leave your lungs and into your blood so it can go to the heart and be pumped to your tissues. Alright, now we'll talk about the components of the alveolar capillary membrane. There are 4 distinct components of this membrane. The first layer is the liquid surfactant layer. This will line the alveoli. And this phospholipid is what helps to lower the surface tension in the alveoli. If that wasn't there, the alveoli would collapse on itself and become non-functional. The second component is the tissue layer, or the alveolar epithelium, which is comprised of simple squamous cells. Now 95% of this surface are flat and pancake-like. These are called squamous pneumocytes, or type 1 cells. Now, the gas molecules can easily pass through for gas exchange here. Type 2 cells are also called plump granular pneumocytes. These are the cells that actually produce the surfactant, and they also aid in cellular repair. Type 3 cells, or the wandering macrophages, roam around the alveoli, ingesting foreign particles as they wander through the alveoli. So basically trapping stuff that shouldn't be there and destroying. Now these macrophages are able to travel through the alveoli due to small holes between them called the pores of Kohn. Alright, the third component of the alveolar capillary membrane is the interstitial space. Now this is the area that separates the basement membrane of the alveolar epithelium from the basement membrane of the capillary endothelium, and will contain the interstitial fluid, the fluid in between physical tissue. Now this space is very, very small, so small that the membranes of the alveoli and the capillary appear to be fused together. So this is a very small potential space between the two. Now if too much fluid gets into this space, you'll get interstitial edema, and those membranes will separate, and it'll make it harder for gases to actually be exchanged. The fourth component is the capillary endothelium, which is simple squamous epithelium that contains the capillary blood and also the red blood cell. All right, now we'll move on to pulmonary function testing. Now these will measure lung function in terms of various volumes and flows and capacity. Now when you're measuring lung volumes, what the patient is instructed to do is first they will be told to breathe normally, so they can get a baseline reading so they can keep the patient calm also. Then they'll be told to take the deepest breath possible that they can and force all the air all the way out. So taking a deep breath in and taking a deep breath out. And then from that, various volumes are recorded. Now there are various volumes and capacities, and here are some measurements. And the volumes will differ based on your age and your height and your gender and your overall fitness. And we'll talk about some of these capacities and some of these volumes in the next few slides. All right, the first one we'll talk about is TV, or tidal volume. This is the amount of air that will move in and out of the lungs in a normal breath. So think of the tide at the beach going in and out. There's no extra effort needed. This is what you do when you're at rest. Now the normal volume is about 500 milliliters, but of course that will vary depending on your age and your sex and your height and your general health. The next one, the FRC, the functional residual capacity. This is the volume of air remaining in the lungs at the end of a normal expiration. So whenever you breathe out, the air that's remaining in your lungs is the FRC. So the next one, the IRV, inspiratory reserve volume. Anytime you see the term inspiratory, that means to inhale or to breathe in. So it's the amount of air that can be forcibly inhaled on top of a normal inspiration. So this is taking a deep breath in. So you're forcing air into your lungs more than what you normally would. Or the opposite of that would be the ERV, the expiratory reserve volume. Expiratory means to exhale or to expire. So it's the amount of air that can be forcibly exhaled after a normal expiration. So this is taking a deep breath out. The next one, the RV, residual volume. This is the volume of air that remains in your lungs at all times. There's no way to physically get this air out of you other than being injured, say by a gunshot wound or stab wound. Your lungs basically are balloons that always stay inflated, due mostly to the residual volume that's always keeping your lungs inflated. When someone's lung collapses, this air has escaped the lung. So no matter what you do, normally you cannot get this roughly 1,000 milliliters or 1 liter volume of air out of you other than being injured. And last one here, VC, the vital capacity. It's the maximum amount of air that can be moved in and out of the respiratory system in a single cycle. So this is the same thing as taking a deep breath in and forcing all that air out. All right, now we'll talk about flow rates. These will measure flow rates coming out of the lung at various points during a forced vital capacity, or the FVC. Or in FEV1, this is the forced expiratory in 1 second. So a normal healthy person can exhale between 75 and 85% of their FVC in 1 second. But someone who has obstructive lung disease will take longer to exhale. It takes more effort for them to get the air out. So someone in this kind of condition can exhale less than 70% of their FVC in 1 second. See the next one, the PEFR, the peak expiratory flow rate. It's the maximum flow rate, or the speed of air that the person can rapidly expel after taking the deepest breath possible. So basically, how fast can you blow out the air that you just inhaled? This is measured in liters per minute and should always fall within a normal predicted range. This is a good test to reflect how the larger airways are functioning, and also to monitor some diseases like asthma. All right, now we'll talk about pathology connection with the lower airways. The first one, atelectasis, is a condition in which the air sacs of the lungs either partially or totally collapse. This is the formal name of a collapsed lung. Now the cause may be a patient who either cannot or will not take deep breaths to fully expand their lungs, which will keep the passageways open, which will stimulate the production of surfactant. Now surgery or pain or injury to the thoracic cage often make it difficult or painful to have a deep breath. So this can lead to the collapsing of a lung. Patients who cannot cough up secretions are also at risk for this condition. And the buildup of secretions can lead to pneumonia within 72 hours. All right, speaking of pneumonia, this is a lung infection that's caused by a virus or a fungus or a bacterium or by chemical inhalation or by aspiration. This will result in the inflammation of the infected area with the accumulation of fluid and then cell debris. Now, some pneumonias can actually destroy lung tissue, and severe pneumonia can lead to death. Here are some general locations of various types of pneumonia. See the first one, a bronchopneumonia. You see at the bronchiole levels here, these little red circles, and how they affect the alveoli. Next one, lobar pneumonia, where you're affecting entire lobes of the lungs. And then interstitial pneumonia, where you're affecting the interstitial space. The next one, TB, or tuberculosis. This is an infectious disease that will thrive in a high oxygen setting, such as the lungs. When you have this condition, you get lesions that form in the lungs, and these lesions are called tubercles. And the bacteria that form these can lie dormant for years. Now, if this goes unchecked, you can have a vast amount of lung damage that can occur. And this can be treated with medication, but there is some concern recently that some forms of TB have become very resistant to drugs that would normally be used to treat the disease. So this will lead to a high mortality rate. Our next one, COPD, chronic obstructive pulmonary disease. This is a general umbrella term that's used for conditions that are associated with cough and sputum production and dyspnea and airflow obstruction and impaired gas exchange. So COPD isn't just one condition. It is a general term that encompasses several diseases that have these types of symptoms. Now, COPD is the fourth leading cause of death in the United States. This is a group of diseases in which patients have difficulty getting all the air out of the lung. And because of this, they often have large amounts of secretions and large amounts of lung damage. It's often a combination of emphysema and chronic bronchitis. All right, asthma, that's a chronic inflammatory illness of the airways. It affects about 25 million people in the United States. This is the most common chronic disease of childhood and of younger adults. About 80% of the cases develop before the person is 45 years old. Now, this is a potentially life-threatening lung condition because the airways of the lungs constrict, often in reaction to an allergy. And the airways constrict in a bronchospasm that makes it very, very difficult to exchange gases. It becomes very difficult to get the air into the lungs, but it's even more difficult to get the air out of the lungs. So what you have here is what's called gas trapping, the inability to get air out of them. So this will lower the amount of oxygen in the blood, but also will increase the levels of carbon dioxide in the blood. And neither one of those is a good situation. Now, asthma can be controlled with medication. Some common symptoms of asthma, episodic wheezing, shortness of breath, cough, and chest tightness. Now, some common triggers for asthma, allergens, inhalants, viruses, exercise, even cold air, an asthma attack. And some chronic diseases can also be a trigger for asthma. Here's a comparison with asthma and emphysema and how they affect various parts of the lungs. The first one, this is how a normal bronchiole should look, fairly wide open, so you can have more air moving in and out. But someone who's having an asthma attack, what you get is the narrowing of the space that the air is that's able to flow through due to the contraction of the smooth muscle. And on top of that, you get an excess amount of mucus that gets made. Now, this image down here, you're comparing emphysema. This is how the lungs should normally look, and it's how the alveoli clusters should look. But with emphysema, these walls have become very, very loose, very unable to function. So it's harder to get air out of the lung. And you'll have these little pockets of very loose, very floppy-like alveoli that at this point don't work anymore. All right, in this table, we have some more detail about asthma and some COPD diseases, chronic bronchitis and emphysema, and their descriptions. On this table, we have some common triggers for asthmatic attacks, including allergens, inhaled irritants, viral infections, cold air, exercise, other factors, drugs, so on. All right, emphysema. This is the abnormal enlargement of the distal airway spaces and also the destruction of the alveolar wall. And probably the worst thing about emphysema, it is a non-reversible lung condition. Even if you were to stop smoking immediately after being diagnosed, once that lung tissue gets damaged like this, you cannot get it back. It's going to be gone forever. So the alveolar air sacs become non-functional because they have lost their elasticity and basically become floppy pieces of tissue, and they just don't work anymore because structurally they aren't the same anymore. So it becomes much more difficult for gases to diffuse between the lungs and the blood, and also the lung tissue will become much more fragile and easily to become ruptured. Emphysema affects 2 million people in the United States, and the majority of these cases are caused by smoking. But some cases are caused by genetic factors. Between 60,000 to 100,000 people have a genetic deficiency of what's called alpha-1 antitrypsin. So the lack of this protein being made due to a genetic defect leads them to develop emphysema. Whether or not they are a smoker or non-smoker, it's all because of a genetic defect. Here's a side-by-side comparison on how to differentiate between COPD and asthma. You have some common diagnostic markers. Then you have COPD characteristics here, and asthma over here, such as the age of the patient when diagnosed. For COPD, it's typically over the age of 40, but for asthma, it often happens in young adulthood or even childhood. For coughing, for example, For people with COPD, it's a productive cough, but usually that occurs in the morning. Asthma sufferers, the cough will usually precede a asthmatic attack. So it's a good comparison of both COPD and asthma, how they are similar and how they are different. Our next one, chronic bronchitis. This leads to a productive cough and the enlargement of the mucus glands and hypertrophy of the airway smooth muscle. And those who have acute bronchitis, this is a temporary and common lung condition. This can affect people of any age. And this differs from chronic bronchitis because it is reversible and there is no permanent structural changes, which is quite different in chronic bronchitis. So there are 9 million people in the United States that suffer from chronic bronchitis, and cigarette smoking is the major causative factor. And with this condition, you get an increase in size and also in number of the mucus secreting glands. And you also get a narrowing and inflammation of the small airways. So not only are you getting a much narrower space in which the air can flow, but you're adding on top of that are thicker secretions of mucus, which makes it even more difficult. So the obstruction of the airways is caused by the narrowing of the airway plus the hypersecretion of the mucus. It can lead to a bacterial colonization of the airways. Now, the acute episodes are brought on by respiratory tract infections. People who have chronic bronchitis may undergo repeated episodes of respiratory failure and will frequently develop right-sided heart failure. Now, smoking is a major preventable cause of many respiratory diseases. It's the primary etiology of COPD. Smokers will have more lung function abnormalities than non-smokers. Smokers will show more respiratory symptoms than non-smokers. And smokers will experience all forms of COPD at a much higher rate than people who do not smoke. Now, the age at which the patient started to smoke, the number of packs per day that the person smokes, and whether or not they are still a current smoker are all tools to predict the COPD mortality rate. And even passive smoking seems to increase risk. So children of parents who smoke are going to be at a higher prevalence, develop respiratory symptoms, and also ear infections than children of non-smokers. So just being around people who smoke and smoke often will put you at a higher risk to develop respiratory conditions. Some other things that can cause COPD to develop: air pollution, occupational exposure, asthma, and also non-specific airway hyperresponsiveness. All of these will play a role in the development of COPD. Alright, now we'll move on to the housing of the lungs and its related structures. Now, the lungs are found in the thoracic cavity and are separated by a region called the mediastinum, which contains the esophagus, the heart, the great vessels, and the trachea. Now, breathing in and out causes the lungs to move within the thoracic cavity. To prevent irritation of the lungs moving against the thorax, each lung is wrapped in a sac or a serous membrane called a visceral pleura. Here's an image of the structures of the thoracic cavity. They have the lungs that are wrapped in a membrane-bound sac, and actually it's a double membrane layer. One layer lines the surface of the lungs itself, the visceral pleura, but then that pleura will wrap back around onto the inner lining of the thoracic cage and also on the diaphragm. And that continuation of the pleura is called the parietal pleura. Now, the terms parietal and visceral are general terms in anatomy. If a structure is visceral, it's contacting an organ directly. If it's parietal, it's lining a cavity. So the visceral pleura lines the lungs directly, and then the parietal pleura will line the diaphragm and the thoracic cavity. Now, in between these two membranes is a very small potential space called the interpleural space. Now, here's where you'll find the pleural fluid, which will reduce friction as the person breathes in and out, allowing the lungs to expand and recoil back without rubbing against anything else. We'll now talk about another pathology connection. Talk about the pleural space problems. The first one, pneumothorax. This is the air inside the thoracic cavity, but outside of the lungs. Now, air can enter the thoracic cavity from two directions. The first is a stab wound or gunshot wound to the chest that allows air to rush into the thoracic cavity from the outside. Another way you can get air inside the thoracic cavity, but outside the lungs may develop a leak due to some deformity in its structure or through a disease process. Now, if the air cannot escape, it fills the space meant for the lungs and prevents the lungs from expanding like it normally would for breathing. And this can often be a life-threatening situation. Next one, pleural effusion. This is a buildup of fluid in the pleural space in between the visceral and parietal pleura. Now, the fluid may be pus, or it could be serum, or it could be blood. And each of those will have a different term associated with those, such as if it's filling up with pus, that'd be emphysema. If it's serum from the blood, that'd be a hydrothorax. Or if it's blood, it'd be a hemothorax. Now, the fluids are affected by gravity. So pleural effusions tend to move to the lowest point in the pleural space. If this effusion is large enough, it can have the same effect as a large pneumothorax, which will end up restricting lung expansion. And pleural effusions can be treated by inserting chest tubes inside or into the pleural space to allow for drainage of that fluid. On this image here, on top we have a pneumothorax, also known as a sucking chest wound. How you have the torn pleura here, how the left lung has been deformed due to that, especially during inspiration, that when the person exhales or expires, the torn pleura will go back to the injury site to close it off. This image down here, you have an example of pleural effusion, and the fluid is draining to the lowest point due to gravity. So the needle will be put inside here to withdraw that fluid, thoracocentesis. All right, now we'll talk about the lungs. The lungs are cone-shaped, soft, hollow organs with rounded peaks. These will extend between 1 to 2 inches above the clavicles. Now the base of the lungs will rest on the right and left hemodiaphragm, with the right lung base a little bit higher due to the presence of the liver. Now the medial surface of the lung has a deep concave cavity that will hold the heart, called the cardiac impression, and is deeper on the left-hand side. And the hilum is the area where the root of each lung is attached, containing the main stem, bronchus, pulmonary arteries and veins, nerve tracts, and lymph vessels. And hilum is another term that is a general term in anatomy. Any indented area where you have larger vessels, nerves, lymphatics entering a structure, that's called the hilum. So it's not a term that's just specific for the lungs. You see it with the lungs, you see it with the kidney, you see it with the spleen, among others. The right lung will have 3 lobes, the upper, middle, and lower. These are divided by fissures, the horizontal fissure and the oblique fissures. The left lung only has 1 fissure, the oblique fissure, and so it only has 2 lobes, the upper and lower. Now the area of the left lung that corresponds to the middle lobe of the right lung is called the lingula. Now the left lung only has 2 lobes because the largest part of the heart is located near the left lung area. So that means the right lung will be a little bit bigger, with 60% of gas exchange occurring in that lung. Right, now we'll talk about the protective bony thorax. This is a bony and cartilaginous frame providing a freedom of movement for the lungs. It will protect the organs of the chest, the heart, and the lungs. Now, thorax will include the rib cage, the sternum, thoracic vertebrae, to which each rib will attach. Now, the sternum, or the breastbone, is in the center of the thorax. 3 main parts of the sternum: the manubrium, which is the top part, the body, which is the middle, and then the xiphoid process, which is the pointy part at the end, which is also an important landmark to be able to perform CPR. There are 12 pairs of ribs. This is also known as the thoracic cage. The true ribs are the first 7 pair. These are called vertebrosternal because they connect the sternum directly to the vertebrae. Now pairs 8 through 10 are called the false ribs, or vertebrocostal. These connect to costal cartilage of the superior rib and then to the thoracic vertebrae. And then the last 2 pairs, 11 and 12, these are called floating ribs because there is no anterior attachment. They only attach to the vertebral column. These are ones that are fairly easy to break because there is no attachment in the front of the structure. Here's an illustration of the whole thoracic cage. So we'll start with the sternum. The whole thing, the whole unit is the sternum, but among it are 3 individual components. The manubrium is the top part, body, the part in the middle, and then the xiphoid process. You can think of this as a necktie. You know, the knot part of the tie would be the manubrium, and the length of the tie would be the body. Then the point at the very end of the tie would correspond to the xiphoid process. All right, the first 7 pairs of ribs, 1 through 7, are the true ribs. They connect directly from the vertebral column right to the sternum. The next 3 pairs are the false ribs. They connect the costal cartilage first, and then on to the thoracic vertebrae in the back. And the last 2 pairs, the floating ribs here, only attach to the thoracic vertebrae. There's no anterior attachment. They aren't connected anywhere to the sternum at all. All right, now we'll talk about how we breathe. Now, the respiratory control center is found in the part of the brainstem, the medulla oblongata. And the process of breathing in is called inspiration. This is an active process in which the diaphragm is sent signals through the phrenic nerve, causing it to contract. When the diaphragm contracts, it will flatten out. When it does so, it's going to increase the volume that the thoracic cavity contains because you're pulling the diaphragm out of the way, so the thoracic cage has room to expand. So the volume will go up. And when you increase the volume of a gas, the pressure will go down. This is known as Boyle's law in chemistry. So those two factors, volume and pressure, are inversely related. When one goes up, the other one goes down. So if you take a deep breath in, volume of your thoracic cavity is increasing. Well, volume goes up, pressure will go down. And the difference in air pressure between pressure in the atmosphere and pressure within your lungs will force air into your lungs. Because all air moves in and out of your lungs due to differences of pressure. Here's where you are taking a deep breath in. When you're inhaling, the diaphragm will flatten out, allowing the volume of the thoracic cavity to expand. Volume goes up, pressure goes down, air gets rushed into your lung. And the opposite of that will be true for when you exhale. The diaphragm will go back to its normal shape, so the volume in the thoracic cavity will go down, which means the pressure goes up, so air gets pushed out of your lung. Now, the ease of ventilation, the general moving of air in and out of the lungs, is called compliance. If you have high compliance, there's very little effort required to expand your lungs. If you have low compliance, it's more difficult to expand your lungs. Now, a condition like emphysema can affect lung compliance. You have the bronchioles becoming damaged and wider, which allows air into the lungs, which will increase compliance, but make it much more difficult to breathe out. So for emphysema, the problem is actually exhaling or getting rid of air. All right, exhalation. This is going to be the opposite of inhalation or breathing in. Now, inspiration is an active process, but for exhalation, that's a passive process. The diaphragm will relax, which will decrease the amount of space in the thoracic cavity. Pressure in the lungs is higher than atmospheric pressure, so air gets pushed out of your lungs. Now, while we consciously can influence our breathing rate and breathing depth is normally controlled by how much carbon dioxide is in our blood. If carbon dioxide levels get too high, it means there's not enough carbon dioxide that's being ventilated or being moved out. So if this happens, chemoreceptors in the medulla oblongata send signals to the respiratory muscles to increase the depth and the rate of breathing. You don't want carbon dioxide to be building up in your lungs. See, there are other factors that can change our breathing rate. Now, it will change as we grow and mature into adults. When we sleep, the breathing rate will slow down. Of course, the rate will increase when we exercise or feel very strong emotions, or when we're yawning, for example. Now, other than diaphragm, there are some other muscles that are used, such as the scalene muscles in the neck, the sternocleidomastoid, the pectoralis major and minor muscles. These are a very short list of the muscles that are used within the breathing process. Now, while exhalation is usually passive, it may need to be assisted, such as during certain diseases. The accessory muscles of exhalation assist in the more forceful and active exhalation process by increasing the abdominal pressure. Now, the main accessory muscles of exhalation are the abdominal muscles that push up the diaphragm, or the back muscles that pull down and compress the thoracic cage. And there are some images of some accessory muscles of exhalation, because the whole point is to increase pressures to force air out. So you have the rectus abdominis, the muscles that form the six-pack abs that some men have. The external obliques, the ones that run diagonal on either side. The internal obliques, also running diagonally here. And then the transversus abdominis. So all these muscles help with forcing air out. All right, now we'll talk about some common diseases of the respiratory system. Lung cancer, etiology. The cause is not known, but is linked to smoking and inhalation of carcinogenics. Signs and symptoms: obstruction of airways that interfere with ventilation, weight loss, weakness, coughing, a change in coughing. Some diagnostic tests are used: imaging studies, biopsies, sputum, patient exam, history, bronchoscopies. Treatments can include radiation, chemotherapy, and surgery. Next one, asbestosis. Etiology is a prolonged exposure to airborne asbestos particles. Some signs and symptoms: chest pain, dyspnea, a productive cough in smokers, and decreased lung inflation. Some diagnostic tests: the chest x-rays, decreased pulmonary functions, and hypoxemia. Treatments: there is no cure for this condition, but the goal is to relieve some of the symptoms and to treat any complications, such as infections, but there is no cure. Acute bronchitis. Etiology: this can be viral or bacterial. Some signs and symptoms: the inflamed mucous membranes of the trachea and the bronchi, expectorating or a dry cough, shortness of breath, fever, rales, which is a raspy sound. Diagnostic test: a physical exam. A treatment: if it's a bacterial cause, antibiotics. The common cold. Etiology here is viral. The signs and symptoms: upper airway congestion, cough, sore throat. diagnostic tests, history, and physical exams. Treatments, pain medications, bed rest, drinking lots of fluids, proper nutrition, and of course treating the symptoms. Pharyngitis, this can be viral or bacterial. Some common signs and symptoms: having a red, sore, swollen throat, also the presence of pus. Diagnostic test, history, and physical exam. Taking a throat culture. Treatments, if it's bacterial, you can treat it with antibiotics or an antiseptic gargle. The laryngitis, etiology here could be viral or bacterial, could be due to allergies, or could be due to simply overuse of the voice. Some signs and symptoms: sore throat, having a trouble swallowing, dysphonia. Diagnostic test, history, and physical exam. The most obvious treatment would be to rest the voice. Tonsillitis, etiology, this could be viral or bacterial. Common signs: sore throat, swollen tonsils, dysphagia. Some diagnostic tests, history, physical exams, throat cultures. Treatments, if it's a bacterial in nature, then obviously antibiotics. Surgery if necessary. If this becomes a chronic condition, then surgery may be an option. Influenza, or the common flu. Etiology, this is a viral condition. Signs and symptoms: fever, coughing, body aches, headaches. Some common diagnostic tests, history, and physical exam. Treatments, rest, plenty of fluids, pain meds, and then treating the symptoms. Pneumonia, this could be bacterial or viral or fungal. Some signs and symptoms: a productive cough, having chest pains, weakness, dyspnea, general malaise. Some diagnostic tests that are used: imaging, blood work, sputum culture. For treatments, if it's a confirmed bacterial infection, then the use of antibiotics or antifungals if it's a fungal infection. Pulmonary tuberculosis, etiology here, this is a bacterial condition. For signs and symptoms, if it's primary, there may be no symptoms, you may be asymptomatic. If it's secondary, there will be a cough, maybe tinged with blood. You may have fever, maybe night sweats, weight loss. Some diagnostic tests: imaging, a sputum test, a TB skin test. And for treatments, using antibiotics. The next one, seasonal allergic rhinitis or hay fever. Etiology, allergic agents. Signs and symptoms: upper airway congestion, having watery nose and watery eyes, sneezing. Some diagnostic tests, history and physical exam, and also testing for various allergies. Some common treatments: antihistamines and a preventative allergy shot. See, asthma, etiology here, there are many triggers for asthma, such as allergens or food or exercise or cold air or smoking or inhaling irritants in general. Some signs and symptoms: dyspnea, wheezing, hypoxia, a productive cough. Diagnostic test, history and physical exam, and also some lung function tests. Some treatments, these will include steroids, bronchodilators, anti-asthmatic agents, and oxygen if necessary. Alright, next one, COPD. Talk about chronic bronchitis. Etiology, cigarette smoking and long-term exposure to air pollutants, being middle or being old age. Some signs and symptoms: dyspnea, wheezing, hypoxia, productive cough. Some diagnostic tests are used: history and a physical exam, some lung function tests. For treatments, if it's bacterial in nature, then antibiotics. You can also use bronchodilators, and if necessary, oxygen. Next, COPD, emphysema. Etiology, the cause is not fully known, but it is associated with smoking. In one genetic form from a deficiency in the alpha-1 antitrypsin protein. Some signs and symptoms: dyspnea, wheezing, a productive cough, hypoxia. Some diagnostic tests: history and a physical exam, lung function tests. For treatments, oxygen therapy, bronchodilators, alpha-1 antitrypsin replacement to counteract the deficiency. ARDS, acute respiratory distress syndrome. Etiology, this is a form of pulmonary edema or swelling. Has a high mortality rate and very non-compliant or very stiff lungs. There are many causes. They include shock or sepsis or trauma. Some signs and symptoms: having a rapid shallow breathing with dyspnea, hypoxemia, and fluid accumulation in the lungs. Having bronchi and crackles in the lungs. Some diagnostic tests: arterial blood gases showing respiratory acidosis and severe hypoxemia. Having bilateral infiltrates on x-rays with whiteouts in the lung fields. Those are good indicators of ARDS. Some treatments: intubation and mechanical ventilation, sedatives and diuretics, and in some cases, getting high doses of corticosteroids. Okay, next one, CF, cystic fibrosis. Etiology, this is a hereditary disease that's transmitted through a recessive gene. Signs and symptoms, having an excessive thick mucus secretion, having repeated infections, having a large salt losses, and also having difficult digestion. Some diagnostic tests, having sweat test, and also genetic testing. The treatments will include respiratory hygiene therapy, mucus thinning agents, antibiotics, and pancreatic enzyme supplement to help with the digestion. Alright, we'll end our chapter with our pharmacology corner. And the first item we'll talk about is oxygen. Now, this can be administered as a medical treatment for respiratory and cardiovascular diseases. The benefits of using oxygen as a form of therapy: this reduces the work of breathing by the patient. This will increase the oxygen concentration in the blood, and it will reduce the workload on the heart. Next, we'll talk about drugs for airway narrowing, such as aerosol bronchodilators. This allows for rapid relief of an acute situation with airway narrowing. You can also have inhaled steroids. This is a long-term treatment of a chronic airway inflammation. Now, these will often have less systemic effects than oral or injectable steroids. Smoking cessation is the only method that is known to prevent or slow down the progression of COPD. Stopping smoking or eliminating an occupational source of smoke is the only known method to slow down COPD's progression. Tobacco dependence is a very powerful addiction. Most smokers require 4 to 6 attempts before actually quitting smoking. Even after quitting, some patients will still have a lifelong craving for cigarettes. Many patients will require behavioral counseling in addition to pharmacological treatment in order to quit smoking, such as a nicotine replacement therapy. This can include skin patches or nicotine gum or inhaled forms. And there are drugs that can be given to decrease the desire and the wanting of cigarettes, wanting the nicotine. And those can include such as Chantix or Wellbutrin. Surfactant, this is administered to premature infants whose lungs are underdeveloped and can't produce their own surfactant. Now, the respiratory system is the last system to form as we develop in utero. So babies who are born premature almost always have respiratory issues. So the surfactant is instilled into the lungs, and this will buy time for the lungs of the infant to completely develop on their own. Systemic antibiotics, of course, these are used for bacterial lung infections. Inhaled insulins, this can be used to treat diabetes. And antiviral medications, these can reduce the length and severity of viral infections, such as the cold or the flu. Alright, as I mentioned, we have various classes of drugs that are used to treat some respiratory disorders. We have mast cell stabilizers that will inhibit histamine release. You have mucolytics, which will help loosen mucus. You have glucocorticoids that will help suppress inflammation. You have expectorants that will produce a thinner layer of mucus. You have beta-adrenergic agonists, which will help to dilate the bronchi. You also have antitussives, which will help suppress the coughing. So depending on what you're trying to treat will determine what class of drugs that you should be given. All right, and this brings us to the end of this chapter, chapter number 13. We will continue our anatomy course on our next video with chapter number 14.